Hello, friends, and welcome to yet another episode of Hybrid Unlimited. This is episode 5, and today we have a very special guest. One special guest and one not so special guest.
So I'm the slightly less special guest?
Yes, you guessed right. So we're here in Miracle Mile, Miami, Florida, and we are at Dr. Charles Mahl's office. And we're here to talk about regenerative medicine, stem cells, PRP, prolotherapy, and all of that good stuff. Dr. Mahl is a physician surgeon, and he specializes in the field of regenerative medicine. And we are grateful that he took some of his busy time to talk to us today so that we can hopefully bring some clarity to the field of regenerative medicine and allow the listeners to understand what it's used for, what it's not used for, and what the research says. Hello, Dr. Mahl.
Hi. Pleasure to be here.
Thank you so much for coming, or for allowing us to come. And with me, we also have Dr. Bill Kelley.
So I'm the less special guest. I'm Stefis. Is hero or idol a better term?
Oh my God.
Steph's friend and former clinical instructor back in her days as a student, and
I taught him more.
Fair enough. I'm pretty familiar with regenerative medicine from a couple of years spent working side by side with Dr. Mahl and lecturing on the topic of regenerative rehab and how regenerative medicine and prolo and stem cell and all of those good things transitions into the rehab world, and those two things work together in order to speed up healing.
Mm-hmm. Bill has a practice in, where is it, in Fort Lauderdale?
Fort Lauderdale,
Yep,
Central Fort Lauderdale, called Aries Physical Therapy.
Yeah, check it out if you're in the area. Awesome. So, Dr. Mahl, why don't you tell us a little bit more about your education and your interest in regenerative medicine and kind of your story of how you got to where you are now?
Sure. I have always suffered from back pain, even as a kid. And in spite of that, played baseball. That was my sport. And my back was always the limiting factor on how far I could go in sports. And when I became a physician, what interested me was orthopedics or ophthalmology, which is eye surgery. And I decided on becoming a retinal specialist, which is the inner layer of the eye. This is going back maybe before you all were born. I've been a doctor for about 40 years now, because retinal surgery was a brand new field in medicine. Before that, the success rate of putting a retinal detachment back together was less than 10%. In today's world, it's now 99%. Wow. So it was very attractive to me to do that. I did that for 20, 25 years, but still suffered from backaches. And I ended up having over time 3 back surgeries. Every time I woke up, my back pain was the same or worse as what it was before, in spite of having physicians who were my best friends, who were orthopedic surgeons or neurosurgeons or whatever. Just the routine conventional medicine at that time just failed to give me any kind of satisfaction or benefit. And after 20 some odd years at sitting and standing doing retinal surgery, I could no longer do it and basically was forced to retire. That said, I was out of medicine for approximately a 10-year period, and then decided to go back into it because I was now living in Miami, Florida. And I had remarried and decided it was time to do something else. I spent a couple of years learning about anti-aging medicine, did 3 fellowships in anti-aging medicine, and thought I was going to do some form of anti-aging medicine, because living in Miami, where we have the beaches and the sun, we all want to be eternally youthful. Unfortunately, my back went out on me one more time, and that changed my direction and course. And I was offered the same thing I was offered in the past, which was now having a surgical fusion operation on my back. In addition, they wanted to operate on both of my hips. That was about 15 years ago. So I decided that while not being an expert in orthopedics at the time, there may be something better for me out there. And I decided to research the internet. And in my research, I found the words regenerative medicine and prolotherapy. And again, this is about 15 years ago now, and became an expert in internet knowledge of what prolotherapy was, not necessarily regenerative medicine. But I said to my wife, I'm going to spend X amount of dollars on this. I've read enough that it can't hurt me if it's done in the right hands, and may help me and may solve some of my problems, if not all of my problems in my back. So that said, and I'm going to cut to the chase, make the story a little bit shorter. I found a doctor about an hour and a half north of me here in Florida. And after 2 sessions with where he did my back and my sacroiliac joints and my gluteus muscles, I stood up and hugged him and put my finger in his chest and said, "You're going to teach me how to do this," because I had the time and I had the money. And that led to a 3-year friendship and a 3-year mentorship where this physician basically taught me everything he knew. And then after 3 years, he said, "You know enough." And we became partners. And I spent 2 years with him in his office in partnership. And because it was so far away, I was planning to open this office here in the Gables. When I opened this office, he was in his 80s already. And he closed up his office and became my mentor down here in the Coral Gables office. That lasted just under a year because he developed kidney cancer and passed away. But that was how my entree was to prolotherapy and then regenerative medicine with platelet-rich plasma and stem cells through this older doctor as my mentor, and finding that it helped me tremendously. And basically, it was a new look on approach to medicine. We're now looking at orthopedic and put in quotes surgery or spinal surgery. We're looking at actually ligaments and tendons that hold bones to bones or muscles to bones. And that's usually what goes bad. And you guys see it all the time in your practices in physical therapy and chiropractic work. But what goes bad in most patients that the doctors aren't really attuned to. They're attuned to doing a surgical procedure because that's what they're trained to do. The process of doing prolotherapy or PRP or stem cells is injection oriented. It depends on putting injections in ligaments and tendons and knowing exactly where to put it. And this is not something that a routine orthopedist or even spinal surgeon is trained to do. They're trained to either look at the intradiscal space or the intra-articular space and put an injection in and call it a day. So the concept of treating, let's say, a knee and doing 20 injections, fully treating all the ligaments and tendons, is a concept that's very appealing to me, being a patient and having my back treated and now my hips treated also, but also seeing over the years that I've done this now, many, many successes with both prolotherapy, rejection and generative treatments, platelet-rich plasma injections and variations of such, and stem cells. And this is a whole new frontier in medicine that we're talking about now. It's kind of like the Wild West. You could ask me, is it covered by insurance? And the answer is no, because it's a brand new field. Things like this usually take 10, 15 years for insurance companies to cover it. They want to have lots and lots of level 1 papers to prove its success rate before they'll do it, in spite of the fact that there's lots and lots of research out there now. It's still unapproved. So it's really for a population of people who are middle class or upper middle class who can afford to have these type of procedures done on them. Athletes, I think, were the first people to discover these kind of treatments, because you saw it with Kobe Bryant and Major League Baseball players and football players and whatnot, going either to somebody well experienced in the United States or elsewhere to have these treatments performed.
So what's the premise behind the treatments?
The premise behind the treatments is it's different than your normal routine orthopedic injection, which would be a cortisone injection. Standard of care, for instance, in a typical orthopedic practice would be you hurt your knee, you're going to either get a cortisone injection, then physical therapy, and then surgery. With regenerative medicine, we bypass the cortisone injection and we go right to a regenerative injection into the ligaments and tendons, sometimes into the intra-articular space, because we want to promote healing. A cortisone injection is what we call anti-inflammatory. So it gets rid of the inflammation that the injury has caused, which in turn can reduce your pain or eliminate your pain. But that only holds for so long because it's not doing anything to cause any kind of healing in the initial injury. With prolotherapy or any form of regenerative injections, what we tend to do is cause a good inflammation, like turning an oven up from 200 degrees to 600 degrees and cooking a turkey. We're trying to get your body to actually heal the problem that's occurred and not mask it with an anti-inflammatory medicine like a steroid, because the problem will continue to come back. A regenerative injection is different than a reparative injection or a repair process, because in a repair, you tend to get scarring. We're not talking about scarring. We're talking about the tissue actually coming back to look exactly like it looked initially, which is completely healed, so that you can't tell the difference between the initial injury and the regenerative injected area. They both look the same. So it's a really exciting field. You have to go to doctors that are experienced in learning how to give these types of injections, because the injections are the same no matter what's in the syringe, meaning prolotherapy solution, I would give the same injections if I had platelet-rich plasma injections or stem cells. And stem cells we usually take from the same patient, from either your bone marrow or your fat. Those injections are all given in the same way to heal a ligament or tendon injury. So that's the point. You have to know how to give injections well. You have to know your anatomy well. You're going by nerves, arteries, and veins, so you don't want to hurt anybody. You're not going anywhere in the epidural space, although we have some data now that we can do that too. But most of the time we're treating ligaments and tendons mostly, and that by strengthening ligaments and tendons, we're able to heal all sorts of injuries like whiplash injuries from car accidents, low back pain, sacroiliac joint pain, gluteus muscle pain, piriformis pain, sciatic radiculopathies, typical knee problems, ankle sprains and strains, and you name it.
Do you consider the evidence to be sufficient at this point to conclude that PRP and stem cells are effective treatments for musculoskeletal injuries?
My answer to that would be yes and no. I think there's a host of data out there that prolotherapy is good for musculoskeletal injuries and platelet-rich plasma. In fact, the field of musculoskeletal work and orthopedic work probably has the most data for prolotherapy and PRP or platelet-rich plasma injections, that it does help in musculoskeletal diseases and injuries. As far as stem cell goes, the verdict on stem cells we're still trying to prove. We know that stem cells from your own body, meaning from your own bone marrow and from your own fat cells, or let's say from a liposuction, are inherently better than taking it from somebody else. That much we know. We know that you can buy things that have been advertised as stem cells, like umbilical cord stem cells or placental stem cells or amniotic stem cells. They're not really stem cells by the time it gets to you. Those stem cells have actually been taken out during the freezing process or the sterilization process. So by the time it gets to you, those products have growth factors in them. Those growth factors are actually pretty good, but those growth factors are still less than the amount of growth factors that would be in your own PRP. So in English, it's easier to do your own PRP if you can have a blood draw and you're not phobic to having your blood drawn, that would be the best thing for you.
And it'd be a lot more cost effective as well, right?
Yes, it is, because the products that you buy in these 1 ml aliquots from Amnion Placental have a huge high markup for it.
And is there good regulation for those types of stem cells?
Because these things are so new, that's why you have a glut of companies now selling it. Every week there's a new salesman with a new company selling the same product and telling me why that particular product is the best. And basically they're all the same. But we have the Food and Drug Administration in the United States that's now basically declared war on these companies and said you have to follow certain rules, regulations, and they consider these type of things now a drug also. So we'll see a lot of changes, I think, occur in the next year or two through the FDA actually monitoring these companies. There's been several instances of infection from these companies, lots of misinformation on who can actually do these type of injections. At times you'll have nurse practitioners or naturopaths or people who've taken a weekend course that are giving these injections compared to doctors who've done residencies or fellowships or real specific training to do these things right. So you have to be really, really careful on who you go to right now.
Yeah, let's talk a little bit more about that too, and quickly differentiate between intra-articular stem cells versus intravenous stem cells.
Yeah.
And what each of those promise.
The intra-articular stem cells is mostly in the musculoskeletal field or orthopedic field. You would do an intra-articular injection for a shoulder or a hip or a knee, places like that, or ankle. And those are very, very effective. When you're talking about intravenous medicine of stem cells, you're getting into branches of anti-aging or what you've seen advertised for desperate diseases like Alzheimer's diseases or Parkinson's disease or diabetes. The data really isn't in the United States that IVs for anti-aging with stem cells does anything. We have anecdotal studies that you'll see, someone throw away their crutches and now they're able to walk, or a woman who couldn't speak from Parkinson's disease and now can speak. But there's actually no scientific data out there that actually proves that these things are really, really happening.
From an ethical standpoint, how are doctors just making these huge claims about what it does and kind of like luring in patients based on totally false information?
I think that medicine, like any other field, has its small percentage of people who have a lack of ethics and who are into making money. Simple as that. So that they see an opportunity to prey on people who have desperate conditions, plain and simple.
And just to give you guys an idea, there are doctors out there in South America that are doing these types of treatments, intravenous stem cells, and making all of these like crazy promises about what it'll do for you in terms of healing all sorts of injuries, all sorts of disease, with simply insufficient evidence. And I've even experienced it myself here in Florida. I went to see a doctor that got referred to me by a professional athlete that he had been doing stem cell treatments with. And I was just shocked at just how seemingly confident he seemed selling me this product that I knew from just my own research and talking to more qualified doctors like Dr. Mahl that it was just not true. But he was just lying just straight to my face. And these treatments cost anywhere from $7,000 to $10,000 per treatment. And, there's just not enough data to suggest that it actually does what it does.
Is there regulation against that right now in the U.S., the intravenous stem cells?
There's no regulation that I know about. And any doctor who's licensed can do anything he wants. I think most doctors will stick to what they're trained in. But that doesn't necessarily stop somebody from wanting to do brain surgery if he wants to do that. Hospitals have specific rules, so you wouldn't be able to get privileges to do brain surgery if you were an anesthesiologist. But still, there's enough leeway that people can get away with doing things that they really shouldn't be doing. The things that Stephanie has said have rang true because I've seen patients that come back to me in my practice. A number of different things. The advertising that's out there lead people to believe that it's a one-shot deal. You can have this one intravenous treatment for anti-aging and live forever, or you can have your hamstring fixed forever by one treatment of stem cells. And it just doesn't work that way, as we now find out with patients coming back that these techniques and treatments work, but you have to have them repeated over time. So for someone who goes to Latin America or who has stem cells here, I always tell them in my practice, stem cells is the last thing I want to do, because you're not just signing up for a one-time shot. You're signing up for it. You may need it again in the future, 3 months from now, 6 months from now, 2 years. So suddenly you're not spending $7,500 or $10,000. All of a sudden that becomes a $30,000 investment over time. So what I tend to do is, because I have the opportunity and the expertise in prolotherapy, is I like to start slow, not hurt people. And 80% of the time I can cure people with prolotherapy, which is level 1 regenerative medicine.
Can you explain what goes into the solution of Prolo?
Yeah. Prolotherapy has been around a long time, almost since the 1930s. It fell out in the 1930s and early 40s because that was about the same time that herniated disc surgery came into play. And that was much more sexy and involved more money. You didn't have to know anatomy as well, the anatomy of the whole body and whatnot. So prolotherapy over the years now has been refined, where we basically use solutions of dextrose, which is sugar water, mixed with lidocaine and vitamins. And we now have level 1 evidence that increases the strength of ligaments and tendons by 40%, gives us some further elasticity to the ligaments and tendons. So by treating the injury to the ligament and tendons, we're basically reducing the pain and causing healing. That's the basis of prolotherapy. The next few levels would be platelet-rich plasma is an extension of prolotherapy. These are what we call proliferants, which cause a proliferation in the tissue or an inflammation, but it's a good inflammation that causes a healing response. It's the same way you cut your hand and the platelets come into play and stop the bleeding. This is what we're doing inside the body now, manipulating the platelets. We can actually, here in my laboratory here, I have a way of either giving you platelet-rich plasma injections and waiting 7 days for the platelets to open up and release the healing factors, or I can kill the platelets in my laboratory and take out the growth factors and just give you growth factors. So it all depends on the type of injury you have as to what kind of platelet-rich plasma procedure I do for you.
And that's a technique that you developed here at the lab, right?
Yes, I did that with a group out of Chicago. There's a lot of products I test research-wise. We also do platelet counts too for anybody who's out there now who's having a platelet-rich plasma injection. They should know their platelet count before they have the injection and the platelet count of what the doctor's giving back, meaning the concentration, because we now know that if your platelet count is 200,000, you want to have at least 1 million cells or 1.5 million cells put back in your body for it to have any real effective healing response. So if your healing response is going to be 300,000, that's going to be very poor, considering having over 1 million cells put back in.
That was one of the biggest issues that we saw. We did all did a lit review before coming, and that was one of the biggest issues we saw, especially as it pertains to PRP, that there's lack of heterogeneity when it comes to the types of PRP that people are getting done, like leukocyte concentrations, platelet concentrations, use of an exogenous activating agent, the speed of the centrifuge, the number of cycles that they use, the order of pellet and separation.
The time spent between extraction and injection.
And I've studied all these things in my laboratory here. There's probably over 100 different types of centrifuges with different speeds and times, recommended speeds and times for each one to perform a PRP. And it also depends on how big the centrifuge is and the rotors they have and whatnot. There is no standardization of a PRP for musculoskeletal work or any other field for that
Do you feel like it's
matter.
needed?
It's definitely needed because there's too much leeway between how people do it. So what you may get in one person's office is different from what you'd get in somebody else's office. Now, the way to have that partially solved is by doctors having platelet counts and knowing that if they take your platelet count to start with, then it's 200,000, and then they go through their laboratory procedure with whatever centrifuge they have. If they're able to come up with over 1 million platelet cells to put back in you, then you know you're at least getting effective treatment. But if they're not counting platelets, then you have no clue what you're getting put back in your body. So that to me should be the first standard of care for somebody undergoing platelet-rich plasma injections.
Sounds like a great quiz for the listeners too. If anyone is seeking out platelets or platelet-rich plasma, pop quiz your doctor on that. If they can give you that answer, you're probably at a better place than if they have no clue.
Yeah, please ask questions to your doctor to corroborate the information that he's giving you. Don't just take everything that he's telling you at face value because he's a physician. Ask him questions and make sure that he understands what he's giving you.
And the reason doctors don't do platelet counts is because it's not a cost-effective machine to have in their office. These things can cost $12,000 to $15,000. But if you're doing a procedure on people, you really should have the right equipment, basically. I'm doing research now on a platelet counter from the Netherlands right now, besides the usual platelet counter that I have, where we're trying to have a platelet counter in the $3,000 to $5,000 range for physicians to afford it, so at least they can have some basic means of having a platelet count before they give the shot. And that brings up your other point that you were talking about, the amount of white blood cells and the amount of red blood cells in platelet-rich plasma, which are important too, because you want red blood cells or you want white blood cells in your platelet-rich plasma, depending on what you're treating. If you're treating near a nerve or if you're treating near a tendon, it's different. So nowadays, we want not just a platelet counter, but a complete blood counter too, where we can count the number of white blood cells and red blood cells we have, besides the number of platelets. So that's just a little pearl that's just, like you said, really, really important.
Mm-hmm.
And then the other thing is, don't buy these off-the-shelf products that are coming from somebody else, from amniotic products or placental or umbilical. And the latest buzzword is exosomes. There's no white papers published or proof that it has any effect. Exosomes are cell signalers, pronounce that word better. And they're in your growth factors anyway, so nobody's telling them what to do. You might as well get your growth factors, which basically is the computer chips to tell them what to do.
And companies are claiming to add exosomes to stem cell treatments, and are they just combining it with all kind of regenerative injections? Like, how are they packaged?
Well, they're packaged separately as another add-on for the companies to make money.
Okay, so stem cells plus exosomes.
Yeah, so you just don't need it.
Yeah.
By the way, stem cells is like a $2 billion market, is what we found, which is crazy, right?
That's right.
Yeah.
It's going to be the wave of the future, because you get into all sorts of genetics now. We've broken the genetic code some years ago, so we can take bad genes out of animals and put in good genes and cure paralysis that way. And that's headed down the road for human beings in the next 10 or 20 years. And regenerative medicine is all part of that gene splicing, gene therapy type of work that's going on in the labs now.
Can we quickly touch on the quality of the available evidence as far as PRP stem cell and Prolo goes? When we're trying to appraise the literature, are we looking at patient-centered outcomes like pain and function, or are we looking at more relevant surrogates like the changes that we see on an X-ray or on an MRI?
I think you're going more for what patients talk about as to level of function and a reduction of pain are the two most important things that we look for when we do these studies. Sometimes we can see improvements on X-rays and MRI, but most of the times an MRI shows us and we tell our patients it's 50% more damage than what patients really complain about. Or a patient's complaining of pain, but you see so much damage on the MRI that you don't really know where is the pain coming from.
It's not specific.
Because they're so specific that they give you too much information. So I think we have enough studies, at least in the musculoskeletal world, to tell us that range of motion is improved with shoulders, knees, hips, and reduction of pain, and cadaver studies too that are showing strengthening and thickness of tendons, tendons and ligaments.
Sorry, I was just going to ask: are there certain qualities of patients that seem to do better in your experience versus others?
Younger patients tend to do better than older patients for obvious reasons. They have better immune systems, better healing powers. The concept of regenerative medicine, all regenerative medicine is stimulating the body to help heal itself. So it has that kind of holistic approach too. And younger people have better immune systems that we can basically boot up when we're giving an injection of platelet-rich plasma or stem cells or prolotherapy. It's turning on your inner body signal to help itself too. From having that off sign and ignoring the problem, we're able to turn the signal on to let your brain think that there's a new problem in your body and to start sending proteins and chemicals down there and growth factors to heal it. So that's an important point.
Yeah.
Older people we're finding with stem cells, don't necessarily do as well as younger folks.
Does that change? Does that change your management of older versus younger people?
It definitely changes mine because I hesitate to do bone marrow stem cells on older folks. I'll do more fat stem cells on older folks, but to put them through major procedures that can cause them pain or add more misery to them, I just don't want to do.
What is the procedure for those that don't know?
You're talking about for stem cells?
Yeah, to remove it from the bone marrow.
For when you do stem cells on a person, the best place to take it from, there are several different places, is the iliac crest, which is the back of your bone. And basically, the way to do it is to have really good anesthesia because the process can hurt if you don't have good anesthesia. And then you basically make a hole through that iliac crest with something called a trocar, which is basically a big needle. And you pull out 10 cc's of blood to 60 cc's of blood. And then we centrifuge that down in our laboratory to give us the stem cells. And the alternative way is to take fat, doing a liposuction, typically like a plastic surgeon would do a liposuction. Some people do it from the front of your body, from your abdomen. That's how I do it. Some people do it from your glute muscles in the back. And take fat. Now, in the United States, the fat that we do now is not really stem cells. It's more for what we call a fat graft, which in English would mean for you, if you have a defect in a rotator cuff in your shoulder, rotator cuff tear, or in a hip tear or a knee tear, we're filling the gap with the fat. And that in itself has lots of growth factors and proteins, maybe some stem cells. But the FDA has stopped using fat for stem cells in the United States. That much you'd have to go overseas to have fat stem cells done. So we have some pretty rigorous rules in the United States about how we do certain stem cell procedures, which I think are good by the FDA. They fall short of policing the amount of people who are advertising procedures that are sham procedures. So that's where the FDA and the licensure boards needs to come in better for us.
So I have one more question for you as far as the quality of the research. Do you consider that there's adequate sham control on how to separate the true benefits from these treatments versus to placebo?
I do, yes, because when you've been in the field a while, you know who the good researchers are and who the ones who are just not there. So we have some good names in the field. Dean Reeves is one name out of Kansas City. David Rabago, I forget where he is, maybe Wisconsin. These are people who are active researchers. They have active programs in research, and so they have the reputation for us of of doing good work. There's a fellow named Hernigo, I think out of France or Spain. So these are we have a group of probably half a dozen names that we follow that are producing really, really good work. And most of us know who the sham people are too.
And that's something that we found in our review of the literature, is that there's a lot of ongoing pre-registered trials, right? And as in the early history of any treatment or intervention, you get a lot of stuff that you don't know where it came from, a lot of stuff that emerges.
Yeah.
So it's going to be interesting to see how it evolves when we.
That brings up a pet peeve of mine,
yeah,
which is there's an internet website called clinicaltrials.gov that anybody and their brother can sign up for and say they're doing a clinical trial.
Yeah.
But what you alluded to is once the doctor signs up to do that, there's no follow-up or they drop out.
Yeah.
So in the beginning, they sort of run it as a sham maybe.
Yeah.
I don't know if I'm saying the right thing or get in trouble. But for a year or so, they can get away with this and appear in quotes righteous.
Yeah.
And then they don't follow through with any data or anything else. And these are what we call self-funded studies, meaning that the patients are paying for it themselves. And I can think of, I'm not going to name them, but 3 or 4 studies that are out there now and have been out there 3 or 4 years with no data coming out yet.
So it's just a way to sort of bypass the approval process
and have some appearance of legitimacy.
Yeah.
Wow.
And
how can you solve that problem?
I don't know how to solve it. It's government tried to do it thinking they were being helpful, and now they're realizing that it's sort of turned around on them. So hopefully they'll figure out some way to.
Right, because we do need some sort of pre-registering.
Absolutely.
In medical trials, right?
Absolutely. The good people are doing the right thing, but you still got that percentage of people out there that are manipulating that system for their own well-being. And by the time you get to them, they're out of business.
Do you see it too with the stem cell companies that are quote unquote questionable companies throwing a lot of money at their own research to make it sound better than it is? I mean, I know we see that a ton with pharmaceuticals. And again, in the supplement world, you see that all the time, where they throw some money at some research and some pseudoscience just so that their product looks better than everybody else's?
The answer is yes to that too. That and like you say, that's in every field. It happens all the time in regenerative medicine, all the time. I'm president-elect of the American Academy of Orthopedic Medicine, which is a group of some 250, 300 doctors that it started out orthopedically oriented, and now it's more or less regenerative medicine oriented, which are the leaders in the field of prolotherapy, PRP, and stem cells. And we fight these battles all the time on, how we educate the public better to know who to go to know that people really need a fluoroscope to do necks and backs. If you're going to do neck and back work or spine work, you need a fluoroscope. You need an ultrasound to look at people's shoulders and hips and joints, and at least make sure there's some basic standardization of how an examination is done. And again, the same thing with platelet counting too. If you're going to have PRP done, that the doctor is competent enough or does enough to count platelets. If he's doing one a month, you don't really want to go to a doctor who's doing one a month of anything. There's a saying that it takes 5 doctors in 3 years to find the right diagnosis for patients. So you have to be careful when you have a serious problem.
So after you've gotten any of these treatments done, then we move into the rehabilitation part. So there's a field, or not a field, but what's called regenerative rehab, right? And that's something that, Bill, you're familiar with. Can you tell me just a little bit about it?
Yeah, so that's the branch off of regenerative medicine is our role in the regenerative rehab process. We put forces through tissues every day, all day, whether it be exercise or manual therapies or even some of the modalities that we're still using. And we have the potential to change the microenvironment around where that injection is gone. And that can be either for the better or for the worse. So you really have to understand what's going into these injections, what's happening at the cellular and molecular level, so that you can apply the right sort of stresses, because a tissue like bone that's load absorbing and load transmitting load absorbing is the wrong term, so get rid of that. Load transmitting is going to react differently than to something that is load absorbing, like a meniscus. So you need to understand what tissue is being injected or what tissue you're injecting and working on healing to understand what sort of procedure you put them through after.
Mm-hmm.
And that's quote unquote the field of regenerative rehab, is understanding these nuances so that you can help with cell differentiation. So PRP, stem cell, even Prolo, they've got a range of effectiveness, and you can help push towards the higher end of that range if you're giving them the right sort of exercises or stimulus. Stimulus is the better term. And you can really push towards the lower end of that range if you have no clue what you're doing and you throw them onto anything that may not be the most perfect sort of plan of care.
Mm-hmm.
I think that's important too, because the concept of physical therapy with some semblance of chiropractic care kind of go hand in hand with regenerative medicine, in that you have all these patients that you're working on and you're not getting them better. And those are the patients, that need some form of injections to stimulate their body and get that ligament and tendon better healed. And then when they come back to you after that treatment, they're going to stay in place better. They're going to hold better. They generally do better with physical therapy and chiropractic care afterwards. And there's some states that actually require the MD or the DO to specifically order physical therapy or chiropractic care once they're done with the regenerative injection treatment. Mm-hmm. So I find that really important, and patients come back after having PT. Once the injections are done, they go, yeah, I'm better now. It's holding me. And you find they stay stable for a while until they do something. If they're an athlete, they're going to do something eventually. And then I call it, they come in for tune-ups.
Mm-hmm.
So that's what it's all about.
And that brings up another point of a way we benefit our outcomes as well, because with these injections, we're now getting put at an advantage because we're growing back viable functional tissue, not just scar tissue.
Exactly.
Someone comes in after surgery or a cortisone injection, what you're healing through and what you're strengthening around is scar tissue that doesn't help them stay strong, stay fast, stay mobile. Instead, with these regenerative injections, you're laying down new viable tissue. So our outcomes are just going to look better too, as long as we've got the knowledge base to handle these type of patients, which is sort of a pitfall from some studies I've read as to this not being taught in school or part of the curriculum for most PT programs across the country.
It's not at all. I don't think we even spoke about this.
Do you think that's because the research has to have time to catch up and be more conclusive?
I mean, we could fill an hour-long podcast with the pitfalls of the PT curriculum across the country, but it's partially that, and it's partially because the purpose of the PT curriculum, and I can't speak to other professions as well, is to pass the boards. And the boards are outdated. So if the boards are outdated, your curriculum's outdated, and that just is a perpetuating cycle that doesn't allow these new things to come in quite as soon as they should be implemented in the curriculum.
And it's the same thing in orthopedic residencies. We're training doctors now, even though it's called American Academy of Orthopedic Medicine. We're training pain medicine doctors, sports medicine docs, family docs, anesthesia docs. They're coming from all walks of life to learn regenerative medicine, and it's not taught in their residencies. So I think there are 2 residencies that teach some form of prolotherapy. PRP is just catching on, but more from an intra-articular standpoint, not from a complete treatment of every ligament and tendon, let's say in a knee or a shoulder. Mm-hmm. So it has to catch up. Like you said, it has to catch up.
But in general, do you find the evidence currently to be conclusive, especially for the use of regenerative medicine for the treatment of musculoskeletal injuries?
Oh, yes. Mm-hmm. Yeah. It's
why are some physicians still so skeptical?
Because they either haven't trained in it or haven't read about it. It's A or B, and I'm being polite when I say that. Everything has to take its time to catch on. If they're not trained in it, I've lectured with docs, and we've both lectured, and the doctor goes, I know you do a lot of prolotherapy, and I don't believe in it. And I probably have treated 10,000 patients or more. And I'm not going to educate him when I get an ignorant remark like that. It just, you can't deal with somebody like that. They have to figure it out for themselves. But people are catching on. People are learning about it. Athletes are swearing by it now. So it is slowly getting there. Insurance-wise, I think that if insurance paid for this, they wouldn't be making the profits they're making, because it's a great way to treat pain. And basically what we're doing is we're either preventing or delaying surgical procedures indefinitely. If you're making your living being a surgeon, you have a real problem with doctors like me, because you're not going to them anymore, and you're signing up for your total knee replacement when you can suffer through some pain with injections and have your own anatomy for another 3 to 5 years, or your hip or something like that. So it depends on how you're looking at the world as to where you're coming from.
When I announced on my social media channel that I was going to be talking about stem cell therapy and Prolo with a specialist, I got a couple of messages from physicians that were criticizing these treatments, mainly because they feel like the current research doesn't really account for placebo, which is what Ian and I were talking about before.
Yeah. I mean, we were just talking about, right, and I think you have a lot of interesting thoughts on it, on the ways different researchers kind of design their studies, and whether it's, out of intellectual laziness or out of some sort of bias. But I think there's an interesting, it's like 3 different questions, essentially. Does it reduce pain? I think it can easily be addressed with experience in low quality trials. Then there's, to what extent does it reduce pain different than other treatments? Like, what specific effect, like in terms, because we're always concerned with just pain function at long time points, or in terms of.
I mean, I'm smirking because I'd love to take all of you and any doctor who wants to.
Yeah,
I'll take them down to anywhere in the world: Latin America, Mexico, Ecuador, Peru, where I train and teach. And you'll see people that will hug you and kiss you and cry because you're giving them a shot, and they've suffered for 2 years or more in pain from a hip scar. The scar, forget they had surgery, but just the scar itself is too tight and giving them grief. So you open up the scar, just silly things like that. Or somebody who can't raise their arm more than 2 inches because they have a frozen shoulder or rotator cuff damage, and you inject all the tendons in their shoulder, and suddenly they're raising it to the top like that. Just so many instances like that make you a believer. That's why it's usually the doctors who have not seen it done or read about it that are the ones who are most critical of it. And
we were discussing it earlier, actually, about how it's difficult for us to remove our biases when we read studies that don't speak highly of it, because we both used it.
We're both patients of Dr. Mahl.
Yeah, I've had it done in Canada as well. So I've had my knee, I've had my shoulder, hamstring.
In Toronto?
I've done in Toronto through the Gallia Clinic. I don't know if you're familiar with it.
I may have trained that person, I think.
Really?
Yeah.
And yeah, I mean, I've had success with all of it, with both PRP and with Prolotherapy. So, it's tough to obviously remove the bias, but then I feel like I've also been given proof that it's worked well for me, because I've gone in, had an ultrasound done in my shoulder where I've had a tear. I've had the PRP done. I've gone through the physiotherapy or physical therapy, and then I've gone back and they've been able to show me that the tear isn't there anymore.
Right. We see that all the time too.
For me, I felt like that was good enough proof for me to show that in that instance in particular, it worked.
So my third question that I posed to them was, and I think you have an interesting perspective, which is why I asked the which patients do best question, is I think patients ultimately care about, will it help me? I don't care about averages. I don't care about this condition or that condition. Me, my circumstance, my condition. And I think, and you have some interesting thoughts about kind of where this is going, but with better access to data and the automation of records, we can hopefully make better predictions about who will work for and even to what extent it will work, because there might be things that seem totally unrelated to the presenting complaint that actually predict outcomes better than things we would have thought.
We're coming up with things, talking about American Academy of Orthopedic Medicine, where we have a certification program for doctors in regenerative medicine. We're also having a accumulation of data where we'll send in a database of patients who have shoulder, knee, hip, whatever kind of problems, so that we can basically collate this data and really give you examples of it. I'm also smiling when you ask that question, because it's one of these things that done in the right hands, you can't really be harmed if the doctor knows what he's doing.
There's always a risk-benefit analysis, right?
Yeah, and so like your shoulder was done. If they do it in the right place, they're strengthening that ligament and tendon. That much we know. So you may still develop a tear or rip depending on what you're lifting and what you're doing, but we know that the treatment itself is not going to give you a negative outcome unless the doctor did something wrong or put the needle in the wrong place, plain and simple. That's why you're doing your research on knowing who you go to and where.
One last question, and then we can wrap it up because we're coming up on the hour mark. Why do you think are physicians still using cortisone shots to treat injuries when the current body of literature is pretty much against it?
I think if you've been in practice a long time and you're used to doing something and you see it work, you tend to go to it as first line. I still use steroids too. If you came into me and your knee was really filled with fluid, I would use a steroid to, I would take the fluid out of your knee and then put a steroid in there to counteract the inflammation, and then wait several weeks and start my regenerative process. So there still is a mechanism to use steroids with the right approach. We know that multiple injections hurt ligaments, tendons, and bone. So now that we know that, especially oral steroids too, you get avascular necrosis in your hip, and then you need a hip replacement. But steroids used for the right indications is a good thing. So it's not something we should just throw away yet. And that's the key to that.
All right. So does anyone have any more questions for Dr. Mahl?
That'll do it for me.
No? Ian?
Nope, no questions.
Okay, good. We're going to take a short break, and we'll come back to you with some Florida man and some recent fitness gossip.
And we're back.
Welcome back.
My babies.
No. Please don't use that line. These are my babies.
All right. So we got the sports fitness gossip segment coming up.
Uh-huh.
So there's two things that I want to talk about.
All right.
First, Russia. Did you see this? 4-year ban from all global sports.
No Olympics and no World Cup.
All international sport?
Yep.
Yes, sir.
Yeah. What was it because of? I think they found that they were continuing to like tamper with the investigation or something like that.
Yeah,
So,
it stemmed out of that original doping scandal. I didn't know if they found more tests or false
As
tests or
Russians
any
do.
sort of evidence that wasn't right.
And they continue to test the same samples because they have access to them for 8 years. And I think as the tests develop, they continue to get more positives as well.
Yeah, well, they did for sure.
Mhm.
I remember Russia got kicked out of weightlifting at the last Olympics, right?
Mm-hmm.
And did you see what they did?
Well, their whole last Olympics, they had to compete as an independent athlete of Russia or something like that.
In Korea for the Winter Olympics. In the Winter Olympics, they had to compete under an Olympic flag, right? There was no Russian athletes, so Russians had to individually petition the Olympic Committee to be permitted to compete.
Wow.
Unaffiliated with their country. But in 2016, individual teams were banned, right? That was a big thing. They didn't ban track and field when they obviously should have.
Right.
You know, and weightlifting was a smaller sport that was clearly just
Of course.
not even just blowing by rules, not even paying attention to.
Did you see what the Russian weightlifting team did?
They had their own meet. Yeah.
So the day of during the time where weightlifting was going on in the Olympics, they were running the same weight classes that were competing at the Olympics at the same time, just to show how much they would have crushed everybody by. So they're like, screw the Olympics.
In weightlifting?
In weightlifting, yeah. So they just had their own separate competition in Russia, being like, this is what our athletes would have done.
How do they compare?
While testing positive.
Yeah. I mean, they did great. They did great. They got to take tons of gear and do their own meet. So, yeah, they're probably some of their best results.
I wonder what that means for the World Cup. Do they just compete as independent soccer team from Russia like they did in the Olympics? Or are they
I don't
just,
think so.
you can't qualify, sorry, see you later?
And that's a long time, 4 years.
Yeah. You
On
know
top
what, though?
of what it's already
Honestly,
done.
dude, if one guy tests positive, it's an automatic 4-year ban. You're telling me that this entire country can strategically try to cheat the system,
And they only get
fake tests and do all this shit, and it's like they got a 4-year ban too? Like, it's so much worse.
And you know
It's
what?
so
Yeah.
organized.
Russia is so good at espionage and like back channeling and shady stuff. How the heck did they get caught? I expect Canada to get caught. They're too nice to lie.
Yeah, for real.
Well, I think the idea was it's not a concern to get caught. It's right.
Right, because
It's
they weren't beating the test. They were just not doing the testing.
Yeah, they were so bold. All that matters is that in Sochi that they won. Right, it was all about Sochi.
Right.
Right, and that they had this historic performance. The consequences in international sports governance don't matter because you can easily confuse the public as to the validity of the sanctions and everyone's doing it. You can defend against that. The purpose in terms of I think the Russian government's organization of a state-sponsored doping system is only to win medals, assuming that winning medals actually serves the interests of the Russian government.
Right.
Right.
But then,
international sports.
But could you argue though that it wasn't a net positive for them because now they're going to have to miss 4 years of competitive global sports?
It wasn't. Well, I think you can argue that was a net positive for Sochi, right? And they might have poorly calibrated the consequences in the decade afterwards. But it doesn't matter because that was the revival of Russian confidence in the Putin regime.
Why are sports so important for Russians?
It's war without the weapons. That was the Orwell thing.
Yeah.
Huh?
War without the weapons.
What does that mean?
It's another.
They want to exhibit dominance over
that's a
everybody
classic
else without invading and taking over.
Well,
other
and also
countries.
Russian national identity is something that's very. It's hard to conceptualize what the cost of the Soviet Union's dissolution was to people who believed in Russia's place in the world, that it was the opposite pole of the U.S. and all of a sudden it crumbled and was a fraction of its former influence, and there was a shift in national identity and a loss of this sense of purpose as a people and a nation. And it seems like one of the motives of Putin is to revive that and reassert Russia's place as a key player in the world. Mm-hmm. And that also involves reviving the Soviet sports system that competed, on an equal level with countries in the West, even with a fraction of the population and the wealth, and it's on the same level as armament and political action and economic decision making.
Go ahead.
Has everyone here seen Icarus?
Yeah, I was just going to mention that. Was that the beginning of the scandal?
That was about the Russian doping scandal in Sochi. But what surprised me the most about that whole thing was not that Russia was cheating, but it was just how rudimentary their way of cheating the system was. It was so basic. You're telling me you just screwed the tops off of samples and passed them through a wall?
They were tamper-proof bottles that they were able to open.
Except for when they were successfully tampered with.
Yeah.
But I don't know. I just thought it was just the most I always thought something was going to be so high-tech. They were making synthetic samples. They were doing something, but it's they literally put it through a hole in the wall.
But the thing was, it was you could easily bypass the anti-doping measures if you weren't doping during the Olympics. They were so bold as to say, we want to dope during the Olympics. How can we accomplish that? It was you have to get rid of the sample that is in the testing bank.
Mm-hmm.
Right. True.
Do they get out of competition testing?
Yeah. Not in country.
Not in Russia?
Russia doesn't have any obligation to do anything in country unless it's an international meet, or obviously if their athletes go internationally.
Right.
Where because the idea was USADA was an arm of the state-sponsored doping system. So all they would do was test athletes to understand how they could beat the tests.
Wow.
Oh my God.
Are we all done with that one? Because I have something that I was interested in.
Okay, is it brief?
Yeah, it's brief.
Okay.
So I thought this would be a good one for you and Bill to actually touch on, maybe, because
I don't like talking to Bill.
Same.
Well,
I'm out.
I'll ask you to put aside your differences for this next segment.
Okay.
So there was that guy just recently, big dude, I can't remember his name, pretty popular powerlifter, but he just tore his bicep deadlifting. Something ridiculous like 415 kilos or whatever, right? And every time something like this happens, you see the same comments coming up over and over again where it's this is why I pull hook grip. or what a dummy, he shouldn't have been pulling with his arms, and like all these pretty misguided ideas of why bicep tears happen in the deadlift. So I wanted you guys to clarify that, because I think you had said something earlier about lack of external rotation or something, and how that can lead to those sorts of issues.
Yeah. So, I mean, it's hard to just draw a direct correlation between a particular movement or a particular load and the increased incidence for a particular injury. But there are things that we know could maybe potentially increase the amount of stress and force that goes through certain structures that might certainly increase the chance of an injury like that happening. So one of the things that I look into is the amount of external rotation available at the level of the shoulder, because what happens is that sometimes when people don't have enough external rotation on that shoulder, especially on that arm that's supinated, then your body compensates for increasing the amount of external rotation or supination at the level of the elbow, and the main muscle that supinates the forearm is the bicep. So essentially, you're kind of like activating and straining more the bicep at the forearm to hold on to compensate for the range of motion that's lost at the shoulder. So that's
what's something that somebody could do if they have that issue. They're lacking the rotation in their shoulder. How do you gain that?
I mean, passively from stretch into external rotation, and then also increasing your ability to activate those external rotators in end range, so that when you're in that deadlift supinated position, you can activate those external rotators when they're already semi-shortened to get that last few degrees, because you're only talking small percentages here. It's not like you need to add 20% of external rotation. You just need to add 1 or 2%. Yeah. So by working on enhancing their ability to fire and contract from an already shortened position, you can help force that joint into a little bit more of a full range, quote unquote.
Yeah. And I think you guys would agree that a lot of that can be done in a warm up, and a lot of times it's even good enough to get people feeling like they can actually turn their palm and face the wall in front of them without working too hard to do it.
Yeah, totally.
For sure. It's,
right.
You're not under the same demands as a baseball pitcher who needs 180 degree
the
crazy external rotation.
And if you really can't
enough to get to neutral.
The thing is with powerlifters, I understand what you're saying in terms of the demand that we have for external rotation of the shoulder, but have you seen like how much motion these guys lose? They keep adding more mass and, more weight, and they literally go from being able to do a squat with like where they externally rotate their shoulders to hold onto the bar, to not being able to even hold onto the bar inside of the
where they're like pressing on the plates.
Like they literally have to sometimes press against the plates because they've lost so much external rotation or they can't even do that, and they have like awful pain. They have to like get help to like get under the bar.
Yeah. Do you attribute that to their bench?
Huh?
What do you attribute that to?
You lose it. You either you use it or you lose it. Right? They're just not putting themselves in.
Yeah. Do you think that's a case for more variation in like the assistance work in powerlifting? Like, because they need exposure to different movements to preserve access to those
put your freaking
positions.
hands over your head every once in a while.
Man,
Yeah,
do
like
some
just do
overhead
different
press.
Right?
Yeah.
And especially in an off-season situation or further from meets, right?
Absolutely.
Right. And even low-level exercises can be helpful just for retaining those positions and developing strength in them.
Absolutely.
Yeah.
Just be an athlete.
Yeah.
Yeah. Don't neglect mobility. That's something that even I struggled with at the beginning, that I got so caught up on just trying to get stronger and over specializing on the squat, bench, and deadlift that I forgot all other aspects of human movement and performance. Mobility, flexibility, they certainly have a time and place for everyone, including powerlifters.
Yeah. It's always that tension, right? Because stiffness is adaptive.
Yeah.
And
exactly.
then a lot of the game too is who can stay healthy and not be injured the longest, because how big are his numbers going to drop now that he's got a torn biceps and he's got to wait for
it's the most important part of the game.
6 months.
Yeah.
No, if you're not healthy, you can't continue to compete. Yeah. One quick thing. So a quick test that you can do to see if you have the amount of external rotation that you need is one test that I learned from Jordan Shallow from Muscle Doc. So essentially you supinate both arms. So essentially try to put your arms in front of you and try for your palms to face the ceiling. And if you find your thumbs to be like overly twerking, or you find yourself trying to overly supinate with your thumbs, then that means that there's the motion's coming mostly from the forearms, versus like if you can just put them up and have them face to the ceiling.
We're all testing it here
Yeah.
for everyone who's listening.
Without
We
stress.
all have our palms facing up.
Yeah. And if this doesn't make any sense, just look it up. I actually think I made a whole video about
made
it.
a video.
Elbow,
Yeah, it's one of your first YouTube videos, right?
Elbow pain and actually no, elbow strains. It's in my Instagram, right? Huh? Yeah. Okay, whatever. That's it. Florida man?
The whole reason I showed up today.
We got a Florida man story?
No.
Just do the Florida Man Challenge. Your birthday.
Yeah, let's do the Florida man challenge. Let's do Bill's birthday.
All right. March 22nd for anyone who's out there looking to get me a gift. March 22nd.
Florida man.
Florida man. What do we got? Florida man shoved woman to get at her egg rolls, police say.
Well, that's valid.
Fair enough.
Florida man what?
That's
He
a
wanted
rational
some egg
Florida
rolls.
man.
What did he
Florida man calls police to say he paid for sex and got scammed.
Oh man, you
Nice.
can't do that.
That's not even Florida. That's Miami. That's
Sir,
like,
where are you? You're under arrest. Please stay there.
sir, my illegal hooker stole my watch.
Yeah.
I actually treated a cop who dealt with a lot of those cases. She was one of my patients, and she had all these guys that would come in and be like, so this girl, I thought she really liked me. We got back to the hotel room, and all of a sudden I'm passed out, and my watch and my wallet are gone. And like multiple occasions, or they would take them home, not to a hotel, and all my watches and valuables were gone. And so more often than not, she'd be like, well, do you have a wife? Like, what's the scenario here? Because if we report this, your wife's going to find out. And more often than not, these guys are like, nah, never mind. We can just bury the lead here.
Wow.
And they would eat the cost of whatever got stolen. But these girls would just roofie them, wait till they passed out, and take their stuff and head home.
Dude, didn't Nicki Minaj say publicly that she used to do that?
Yeah.
Yeah.
Was it her?
Yeah.
Or Cardi B? It was one of them. But
I think it might be Cardi B.
yeah, I now that I think about it, it might
That's
have been.
almost something. Just get away with that.
Yeah, but she took a bunch of heat for it. People were like, "You can't just say that.
Yeah,
that's
that's-
super
that-
illegal.
those-
Use
yeah.
this drug dudes and take their stuff." But I don't know what ended up happening with that. Nothing.
Nothing. She's
too
famous.
famous to get in trouble.
Slap on the wrist. Yeah.
What are you looking up there, Colin?
I'm looking up.
You know who we
Florida
should
story.
have? We could
Huh.
literally do an entire Florida man episode if we brought Tony, Real World Tactical,
Oh my God.
on the thing. His whole
God.
life was just dealing with Florida men doing absurd things. You got anything good for us?
Let me see.
Where was he a police officer?
Miami-Dade.
Oh, that's, yeah.
I mean, this is a good one. Florida man arrested for attempting to barbecue a child molester.
Kind of valid.
Yeah.
Nice.
Barbecue?
Florida man wrecks liquor store, blames it on Caterpillar. Not the most likely suspect.
Oh my God. That's
All right.
crazy.
That's enough crazy Florida man.
Yeah.
for
Florida
today.
man's getting out of hand.
Should I
Hey,
do
there was a real one right down the street.
Oh,
The guys that
literally
robbed the
happened.
jewelry store and then kidnapped the UPS driver and used a UPS truck out of all things.
Oh, yeah. There was here.
A million
Yo, I'm
cars
seeing
around here that are just fast.
I've seen a ton of
And 4 people
stuff,
died, right?
like where people are getting upset with UPS and stuff because UPS apparently said they're not going to pay for the funeral, and it was the UPS driver's first day alone. And I'm like,
What?
You can't put that on your face. You can
It's
put
so
blame on a lot of people, but not
yeah, UPS didn't have anything to do with this guy ending up in a freaking wild or a firefight in the middle of Miami. It's like that has nothing to do with them.
Legit.
But people are so quick to just get upset with corporations. It's like,
They're upset with Peloton over the commercial where the guy gives his wife the Peloton.
I saw that. Yeah, your friend posted about that. I hadn't seen the commercial, so I was like,
it's like people are super upset that how dare a husband get his wife.
how dare he get her exercise
yeah,
equipment?
yeah,
What
yeah.
is-
They kinda like-
she looked good already.
Yeah.
That's so ridiculous. It was a woman being upset. Like, was
No, so
another
the
woman upset?
Society's
Society
upset.
is upset
that
Society-
you
is
can't
society a
force a woman
woman?
to exercise.
Or a mix?
Well,
Like, are both genders?
I mean, there's
I
a
mean,
lot of
all
everyone's
genders.
upset. You know,
All genders, yeah. It's
Yeah,
not
a lot of
binary.
people are
Everybody's
upset
upset.
because it's unimaginable that someone likes to exercise and would like a,
Oh my God.
like a spin class at home.
That's ridiculous. Okay.
Should just
That
be
was,
crazy world.
Yeah, shut up. We have to wrap this up, bro.
All right, keep going. Talk more.
Okay, this was episode 5. Thank you guys for tuning in. If you like this episode, if you like our podcast, please write us a review and give us 5 stars because that's what we deserve. And make sure to tune in for every single week, for indefinitely, forever. Every Thursday, new episodes. And if you're ever in Miami, make sure to check out Dr. Charles Mahl, Gen Life Regenerative Medicine. If you guys are looking for PRP, Prolotherapy, or stem cell treatments, this guy's the best in the game. Hayden and I have been clients of his for about 2 years now, and we have so many good things to say about him. He really, truly is an expert in his field, and
he's the best,
and an amazing practitioner and professional. So check him out, Dr. Charles Mahl. Thank you so much, and I'll catch you guys
next time.
Next time. Bye.